Timmy's a 9-year-old male who plays on his school soccer team. Recently, he has been getting very short of breath during soccer practice, so his mom took him to see his pediatrician. Timmy's doctor found that he has a significant heart murmur. Oh snap! What could it be, and what are the priority nursing interventions you must know for not only your tests, but ultimately the NCLEX? Today we're wrapping up cardiomyopathy, or what my mom calls cardiac mayonnaise. What happens when the cardiac muscle gets either too thin, too hard, or even just really big and thick, all leading to a weaker pump, meaning low cardiac output, aka low oxygen to the body. Now, there are 3 different types of cardiomyopathy that affect the cardiac muscle. So we use the acronym Dr. H. D stands for dilated cardiomyopathy. So remember D for distended and thin heart muscles, kind of like a balloon. R is for restrictive cardiomyopathy. So remember R for rock hard, rigid cardiac muscle. And H is for hypertrophic. So remember huge trophy-like, big and thick heart muscles. Now there are 2 categories of cardiomyopathy. It's either primary or secondary. Primary develops all by itself, and secondary is usually caused by hypertension or some sort of valve disease. But before we further break down the causes, let's define what cardiomyopathy is. So the fancy medical definition of cardiomyopathy, cardio meaning heart, myo meaning muscle, and pathy meaning disease. So cardiomyopathy is a disease of the heart muscle, the myocardium, which inhibits effective pumping. Essentially, we have pump failure problems here, which again leads to this less cardiac output, basically meaning less oxygen to the body. So what's really going on in the body? Well, as you guys know, the heart acts like a pump, pumping oxygen-rich blood out to the body from the left ventricle. Now, the ventricles stretch as they fill with blood, and this is the end of diastole, called preload. And then, well, when they fill, they have to squeeze out all that oxygen-rich blood to the body. This is where they overcome all that pressure called afterload. Now, the amount of oxygen-rich blood being pumped out of the heart to the body per minute is what's called cardiac output. All that blood coming out of the heart. It's when the heart cannot pump correctly when we get less cardiac output, meaning less oxygen-rich blood out to the body. And that's when we get loads of problems. So again, we're going to review these one by one, but just again, little overview. Dr. H. D is for our dilated, distended cardiomyopathy. This is where the ventricles sort of balloon out and have very thin muscle walls, as you can see right here. Next is our restrictive, rock-hard cardiomyopathy. The ventricles get super stiff like a brick wall and technically don't pump correctly. And H is for our hypertrophic cardiomyopathy, where the ventricles do the exact opposite. They beef up and get really thick and hard like a big, huge trophy. So let's start with the first one, dilated, which I call distended cardiomyopathy. Now, this guy is the most common out of our 3 wise men here. Here we have distended muscle walls, where the chambers in the heart are being stretched out like a saggy, loose sock, leaving us with big, stretched out chambers and really loosening up the valves so they don't close all the way. This results in a weaker contraction, basically not an effective pump, or no effective systolic squeeze for our blood pressure. And this leads to pump failure, specifically systolic heart failure, where the blood doesn't go forward and now it backs up into the lungs and or body. And when blood backs up, again, this means less blood being pumped out of the heart to the body. And again, this is called less cardiac output, meaning less oxygen to the body. As a result, the body thinks we have low blood pressure. So the body attempts to increase this blood pressure by stimulating the sympathetic nervous system to increase the heart rate. It also attempts to increase the blood pressure by stimulating the kidneys to initiate the renin-angiotensin-aldosterone system. Fancy words for the RAS system, which results in the kidneys holding on to the fluid, which increases blood pressure. But over time, these compensatory mechanisms can no longer maintain cardiac output and the heart begins to fail. So we're gonna see classic heart failure signs and symptoms, all revolving around low oxygen signs and symptoms from this low cardiac output. So low oxygen in the brain, we'll see syncope, as well as mental status changes. Now, exams in the NCLEX love to really emphasize that restlessness and agitation is the earliest signs of hypoxia. So guys, write that down. Restlessness and agitation are usually the first signs that indicate low oxygen. But we'll also see in the heart angina and ECG dysrhythmias, or basically a heart block. And for the respiratory tract, we'll see shortness of breath called dyspnea, so you'll see rapid, shallow breathing. Now, as far as heart failure signs and symptoms, blood fails to pump forward, and now starts to back up in the body and or the lungs. So if blood backs up on the left side of the heart, remember L for left means L for lungs. We hear wet, crackles inside the lungs, known as pulmonary edema. And R for right-sided heart failure, which R means rocks the body with fluid. So we'll see a swollen body with edema, ascites, and even JVD, jugular vein distension. Now, in this distended heart for dilated cardiomyopathy, we also see regurgitation in the bicuspid and tricuspid valves. Since the valves are loose from this distension, they don't close tight enough. So remember, regurgitation means a return of blood into the previous chambers. Fancy words for the blood isn't pumping forward. We're also going to see narrowed pulse pressure, which is where the blood pressure numbers get closer and closer together. For example, our normal blood pressure is 120/80, but it starts getting closer and closer together, turning into 110/90. Now, this is a very difficult topic for most students to grasp, but guys, please just understand that cardiac output is dropping. And lastly, we'll hear a murmur near the S3 location. And this is from the slamming of blood into the stretched out ventricles, sounding a lot like this. Now, as far as diagnostic tests for dilated cardiomyopathy, our chest x-ray is going to show an enlarged heart called cardiomegaly. So guys, remember, a megaheart is cardiomegaly. An echocardiogram, aka just echo, we want to see the dilated and distended heart. We basically just want to see how thin those heart muscles are, so we know how to evaluate how much blood is being pumped out of the heart, measured in ejection fraction. So ejection fraction of 55% to 70% is normal, but guys, dropping below 40% usually indicates that the heart is in some type of heart failure. And lastly, an angiography is used to rule out ischemic heart disease. They basically just inject dye into the veins, which acts like a highlighter to better visualize any blockages of the artery or even poor oxygenated areas. Now, as far as labs, we're going to see a distended heart with elevated BNP, B-type or brain natriuretic peptides, which indicates non-specific stretching or tearing and damage to the heart itself. This is usually an indicator of fluid overload, as in heart failure. But in dilated distended cardiomyopathy, this works too, since the ventricles are being stretched out and getting super distended and very thin, like an overblown balloon. So think of a big balloon that is slowly stretched out under all that pressure. Guys, this is exactly what's happening to our ventricles. We measure our BNP, which means that anything over 100 is not good. So over 300 is mild, over 600 is moderate, and over 900 is really severe. Now guys, I've seen patients with like over 3,000 BNP, so just trust me, it can get like really high. And even some instructors say even as high as 40,000 BNP. Holy guacamole! But again, a little disclaimer, facilities and textbooks, guys, they differ on their exact numbers, so guys, always go with your textbook and facility first. Our numbers here are taken from the NCLEX books and based on NCLEX standards. All right, guys, now that we know what's wrong with the patient, what are we gonna do about it? So always ask yourself, what is the main patient outcome goal? Well, in this case, we need to increase cardiac output, which is gonna increase oxygen to the body. So we use A, B, C, and D drugs. These guys do two things, so please write this down. Guys, these are the hallmark cardiac drugs. You will always show up on the NCLEX, so write these down, guys. These guys calm the heart and drop the blood pressure or the heart rate. And they all do it in different ways. It's kind of like having a big toolbox, so we just choose the right tool for the right situations. Now, guys, we're gonna do a real quick overview, but we go for a deeper dive and break this down to more detail in our pharmacology course. Now, our first A is for ACE inhibitors. These guys end in pril, like lisinopril. These guys drop the blood pressure and take pressure off the heart. So guys, remember, A for ACE inhibitors is A for antihypertensives. And lisinopril ends in pril, so you can say it's like a chill pill for the heart. Less work, less pressure. It's relaxing. So remember, beta blockers, they block beats in the heart. By slowing it down, it's kind of like pumping the brakes on the heart. So remember, beta blockers block the beats like pumping the brakes. So we slow the heart rate down. Now C is for calcium channel blockers. Remember, calcium calms the heart. Our famous ones here ending in D-pine, like nifedipine, or Zem, brand name for Cardizem. So guys, remember, D-pine helps the blood pressure to decline. And Zem, like Cardizem, is kind of like Zen yoga for the heart. It's so calming to the blood vessels and the heart, and in result, the blood pressure drops. So remember, C in calcium channel blockers is C for calming in the heart. Now, D for digoxin, our cardiac glycoside. This guy gives a deep contraction. This is also known as increased contractility, And it also slows the heart rate, known as negative chronotropic. Chronos meaning time, so negative time, less beats per minute. So remember, the D in digoxin is D for deeper contraction. Or we can say digoxin, because it digs for that deeper contraction. But guys, caution, the 3 most common test questions always include, number 1, checking the apical pulse for 60 seconds prior to giving. And number 2, checking the potassium levels to see if they're normal between 3.5 and 5.5. That's a huge priority. And lastly, monitoring for digoxin toxicity. Guys, anything over 2.0, digoxin level is huge. And usually vision changes are the first sign of toxicity. So again, any patient with an apical pulse less than 60 beats per minute, or any potassium less than 3.5, or any toxicity level over 2.0, guys, don't give the medication. Hold the medication and report your findings to the primary provider. Now, the last D is for diuretics, which help diurese the body, aka dehydrate the body. And all of this decreases the blood pressure. So drugs like furosemide or hydrochlorothiazide, now these both end in "ide", so think the body is dry. They dehydrate the body and drop the blood pressure. Now, these guys are potassium-wasting diuretics, meaning they dump potassium from the body and into the body. So guys, please be sure to educate your patient to keep that potassium intake high. Teach those patients to eat green leafy vegetables like spinach and fruits like melons, bananas, and others. Now, if drugs don't manage the condition, then surgery is our last resort. A pump can be inserted into the heart called the LVAD, the left ventricular assist device, to help the left ventricle pump. And our very, very last resort is a heart transplant. Now, as far as treatments for dilated cardiomyopathy, we're going to educate our patients on the acronym DRESS, which is basically diet and lifestyle changes. So remember, say yes to the DRESS. D stands for diet that is low in sodium and low in fat. This helps reduce the blood pressure and take workload off the heart. R is for rest periods to conserve oxygen. E is for exercise to perfuse the heart and prevent deconditioning. S is for stopping smoking and alcohol consumption. I mean, who does that, really? And S is for stress reduction, like quitting nursing school and even your job and living in the Bahamas all day long. Now, that will lower the blood pressure and will take that evil workload off the heart. All right, maybe you can't go to the Bahamas or just quit work like that, but guys, decreasing that stress, it's going to make everything a whole lot better. All right, guys, now that we covered dilated cardiomyopathy, let's switch gears and go into restrictive cardiomyopathy, where we have that rock-hard heart, where the heart muscles get thick and bulge out like a big boulder. All right, so what's really going on here? So as you guys know, the heart muscle is very stiff and hard like a rock, or hard like a brick wall. This doesn't allow for the ventricles to stretch, which if they don't stretch, they can't get blood in. And if they can't get blood in, then this means they can't refill with restrictive cardiomyopathy, since the ventricles can't stretch. Now, this is caused by either genetics or scar tissue buildup in the heart muscle itself. But guys, we'll review the causes in a moment. The main point here is that, again, we have less blood into the heart, which means less blood out to the body. And this less blood out means less cardiac output, meaning less oxygen out to the body. So just like in dilated cardiomyopathy, your heart is not an effective pump anymore. And even though the patho is a little bit different here, our signs and symptoms are quite similar, all revolving around heart failure due to this pump failure, or in this case, from a stiff heart. So in heart failure, we know that fluid backs up into the body or into the lungs, right? And this low cardiac output means low oxygen to the body. So guys, we're gonna see all the signs and symptoms stem from this low oxygen and blood being backed up. So signs and symptoms of low oxygen again. In the brain, we're going to see syncope, but always our first sign is going to be restlessness and agitation, that change in mental status. In the heart, we'll see angina and ECG dysrhythmias, and even shortness of breath, also called dyspnea, and fatigue, called weakness. Now, as you guys know, heart failure signs and symptoms. Left side of heart failure is left for lungs, so we'll get wet lungs like crackles and pulmonary edema, and right side of heart failure is right for rock the body, so we'll get a swollen body filled with edema, ascites, and JVD, that jugular vein distension. Now, as far as the causes of restrictive cardiomyopathy, it all revolves around the 2 Ds, darn genetics and damage to the heart. For genetics, the heart gets hard like a rock from particles that deposit into the heart muscle itself. Kind of like bulletproof glass, these deposits of particles make the heart rock hard. So when proteins are deposited into the myocardium, the heart muscle, it's called amyloidosis granulomas. Where the heck do they get these names from? It sounds like Mary Poppins. Supercalifragilisticexpialidocious, amyloidosis, granulosa. Or when small areas of inflamed tissue are deposited, it's called sarcoidosis. And lastly, if iron particles are deposited, making a person be like Iron Man, it's called hemochromatosis. And our last D is from damage, usually caused from radiation, where we have a lot of radiation to the heart, kind of like in chemotherapy patients or other patients with a lot of CT scans or chest x-rays. Your heart will actually get a lot of scar tissue around it and really get harmed. So we do the same test as we always do, but here's the weird thing, guys. Everything is usually normal. So our chest x-ray, it's gonna show a normal heart size because everything's just kind of stuck and really hard. But maybe sometimes there's pulmonary congestion from the heart failure. Now, the biggest difference is the heart is not enlarged like in dilated cardiomyopathy. The heart's just stiff here, guys. We'll also have a normal echo, normal ejection fraction, meaning the heart is pumping out enough blood, over 55% ejection fraction. And lastly, our MRIs can rule out pericarditis. All right, guys, now that we know what's wrong with the patient, what are we gonna do about it? Well, again, just like in dilated cardiomyopathy, we need to increase that cardiac output, basically meaning increase oxygen to the body. But honestly, there's not much we can do here with our rock hard heart. So if possible, we can treat the causes, and usually the only cause to treat is by decreasing radiation exposure. But usually, since it's always genetic, we usually have to do a heart swap, aka a heart transplant. Now, last but not least, the most deadly cardiomyopathy of them all. Not as common as dilated cardiomyopathy, but guys, this one is the biggest cause of sudden death in young active children. Now, guys, since this is so deadly, it's usually diagnosed early in childhood, because it's only caused by those darn genetics. Because remember little Timmy from our case study in the beginning of this video? Well, this is Timmy's condition. So let's break down exactly what Timmy's going through. Hypertrophic cardiomyopathy is the must-know for your exams, since it's the most deadly, and it's the most likely to be tested. So hypertrophic cardiomyopathy, think thick, huge, trophy-like heart. The heart becomes really thick and hard. Now, the big issue here is that big, fat, thick, trophy-like septum, which limits the heart from filling. Guys, this means less blood in, so less blood out. And again, less cardiac output, this less oxygen out to the body. Now, we have that with every condition. But here's where the deadly stuff happens all of a sudden. Our big, thick cardiac muscle here where our trophy is starts to grow. This goes from not obstructing the aortic valve like during rest when there's no pressure on the heart to suddenly blocking all of the oxygenated blood 100% going out to the body. This happens during sudden straining like during exercise like running wind sprints and in soccer practice, or even squatting down or bearing down like when lifting weights. This sudden strain on the heart causes more bulging out of that heart muscle. And this bulging out suddenly obstructs the aortic valve, blocking all oxygenated blood out to the body. Because guys, always remember, oxygen is the money of the body. No oxygen means no life. The body goes broke and dies. We're talking brain death, heart death, and even sudden death in a matter of minutes. And wait, the most scary part about this whole condition is that most kids don't even know they have it until it's too late. So guys, that's why it's screened so early in life. Now, what are the signs and symptoms of hypertrophic cardiomyopathy? Well, we usually see no signs and symptoms until sudden strain on the heart. So it goes asymptomatic without signs and symptoms and usually undiagnosed. So kids go undiagnosed for years until they join a sport and then suddenly drop dead during this exercise, as the heart obstructs that aortic valve and cuts off all oxygen to the body. So our signs and symptoms are going to see low oxygen. We'll see shortness of breath and difficulty breathing, also called dyspnea. Low oxygen in the brain will see syncope or even dizziness and passing out. And low oxygen in the heart will have angina or even chest pain, ECG dysrhythmias, and even sudden death. Now, as far as diagnostic tests, to help Timmy here and all our future Timmies out there, guys, early detection is key to survival. Providers will listen to a very specific heart sound called a systolic ejection murmur. This murmur is present upon bearing down. So little Timmy will be asked to bear down and strain in the doctor's office as the provider listens to his heart. As far as imaging like a chest x-ray, guys, this is going to be normal. But the echocardiogram, this guy will show septal wall thickening. Remember that big trophy in the center of our heart? Yeah, that thickening of the septal wall, think trophic. T for thickening, T for trophy. This is the trophic condition for little Timmy. Now, labs can be used like a genetic blood test and even a biopsy to look for myofibril disarray. Now this is just a swirling and tangling of muscle fibers that get all clumped together like this. Kind of like tangling shoelaces of a cardiac muscle. Cardiac muscles are supposed to lay like this. Now as mentioned before, I'll mention again, genetics is the only indication here, guys, so write that down. Huge test tip. Again, kids are screened at a very, very young age. So guys, genetics. It usually always shows up on tests. Now to treat this, it's a very simple surgery called a myectomy. Basically, we just remove that little bulge inside the heart, kind of just slice it out. Now again, surgery is usually always done since the condition can flare up at any moment, at any time, causing sudden death. Usually we don't mess around with this, so we go straight to surgery. But if for some reason the patient will be put on heart drugs, then we only give B and C drugs, like we reviewed earlier. Now B is for beta blockers. These guys end in LOL, like atenolol. They block beats in the heart. Slowing it down, kind of like pumping the brakes on the heart. So guys, remember B for beta blockers, B for blocks beats, like pumping the brakes. So we kind of slow the heart rate. Now C is for calcium channel blockers, C for calms the heart. This guy drops the blood pressure. And the big ones for the NCLEX are nifedipine and dilantazem, brand name Cardizem. So again, remember D-pine helps the blood pressure to decline. And Zem for Cardizem is kind of like Zen yoga for the heart, calmed and relaxed. But guys, caution, we never give the 3 Ds. Big no-no for hypertrophic cardiomyopathy. So our 3 big Ds are D for dilators like nitro, D for digoxin, and D for diuretics. All these guys can worsen the obstruction in hypertrophic cardiomyopathy. So educate little Timmy to tell his doctor to avoid the 3 Ds. All right, guys, now other common test questions come with safety, and the NCLEX loves to test you on safety. So warning against strenuous activity like lifting heavy weights, bearing down to even poop, or even sudden position changes can cause an episode, ultimately leading to sudden death. So guys, teach little Timmy about his next soccer practice to be safe and go slow. All right, guys, that wraps it up for cardiomyopathy.